And Toby, when we excise the specimen, there is a large defect, huge defect in the perineal. What will you do? How do you close this defect? What are the options?
There are several options, but still we have not found the perfect option. You have the option to do a primary closure of just the fat and the skin. With this method, you have a high risk of infection and adhesions. You have the option to use some kind of muscular flap, like the ram flap, tram flap, gluteus flap, gracilis flap. But even with that, you have problems with infection and breakdowns. Recently, we have biological meshes that we can use, and they are frequently used nowadays, but also with that, you have infection problems and adhesion. So presently, there is no very good method to close the defect in the perineum. We have problems with that.
Is it really different from the standard APE?
I don't think so, really. I think with the standard APE, you also have wound healing problems, and it increases with neoadjuvant radiotherapy. And I think it's similar both for the conventional type of APE with a little smaller defect and the more extensive. But with a wound in the perineum, you have healing problems.
In which patient group would you recommend flaps? I mean, patients who receive preoperative radiotherapy, or in patients who had SQNL type Extra-Levator APE, or in which patient population?
I think that if you do a more extensive operation, removing more fat in the ischoanal fossa, or removing a little bit more of the sacrum, for example, or if you have a patient with risk factors for infection like smokers, diabetics, neoadjuvant treatment, then a flap is probably a better choice than a primary closure or a mesh.